Well, thank you to the scientific committee and particularly to Dr. Shoaib for inviting me kindly to invite me to speak to you. I'm going to tell you about immunoglobulin monitoring in our pediatric cohort at Sidra in Doha. Um,
Okay, sorry. So
so a bit of background. Basically, this is an area that we've been interested in for some time. Back in 2018, 2019 in the UK, we authored guidelines for the monitoring and immunoglobulin replacement after B-cell targeted therapies in autoimmunity. So this is a really under-recognized problem. We find that people may not be monitoring and patients may be having recurrent infections which are avoidable. And so there are guidelines that set in 2019. There's now Quad AI guidelines from 2022. And they effectively recommend that you should always undertake baseline immunoglobulin measurements and then 6 to 12 monthly after that. There are some specialty-specific guidelines, for example, in SLE. Most of this literature is based on adult studies. So we wanted to look at our pediatric cohort. We wanted to see what was happening in terms of immunoglobulin monitoring, and we wanted to audit our practice compared to the 2019 and the 2022 recommendations. So we looked for all patients who had received rituximab at our institution, and we assessed immunoglobulin measurements, how frequently these were being done, what were the results, and then we defined hypogamma as IgG below the lower limit of the age-related reference range, and we recorded hypogamma at baseline and during follow-up. And we also noted whether patients had needed to start immunoglobulin replacement. So the cohort was about 60 patients, of which 55 were autoimmune. The remaining were lymphoma. The biggest group was nephrotic syndrome, 26 patients or 43% of the cohort. 15 patients or a quarter were SLE, and smaller numbers of other rheumatology and neurology patients. Essentially, at baseline, the clinicians were very good. About 90% of patients had baseline IgG measurements. And in fact, importantly, more than a quarter of the patients had abnormal IgG at baseline. During follow-up, not so good. 77% of patients had follow-up testing of immunoglobulin. However, there was quite a significant range of measurements between 1 and 10 time points over a median follow-up of 1 to 36 months. Technological hitch. I just focus on this one particular patient who was. Yeah, I can see something, but you can't see it. So, can we go back to the previous slide? Great. Okay. Okay. Great. Sorry about that. Okay. This is a little bit of detail to take in, but I'll just focus on some of the highlighted points from this. So the first point to say is, what about baseline IgG testing? I said it was overall about 90%, but you can see clear differences between the specialties. So nephrology only measured baseline IgG in about 3/4 of patients, whereas the other specialties, it was 100%. What about baseline IgG? Well, you can see, importantly, in neurology, it was normal all the time, whereas in the other specialties, rheumatology, nephrology, and oncology, it was low. During follow-up, you can see rheumatology were very good at measuring. So rheumatology get a lot of credit here. They were very good at baseline, and they were very good during follow-up. If you look at oncology, the red, you can see although they only measured in 3 out of 5, all of them were abnormal. And if you look further down in the oncology, you can see there, which you can imagine, of course, their regimens are more intense. They are more immunosuppressed with chemotherapy as well as rituximab. And you can see a significant fall in the IgG. Whereas if you look at rheumatology, interestingly, because a lot of patients have SLE, they actually have polyclonal hypergamma to start with. So it starts towards the high end, comes down, but starts to recover again as the B cells recover. I want to focus on one particular patient who had SLE, and this is a very interesting patient who we're evaluating in another research study that's funded. So basically, this patient, who was a 6-year-old girl, dropped her immunoglobulins markedly just after a single BCTT cycle. That's very unusual. So it went from a baseline IgG of 7 down to 3 just after one cycle and stayed low. Of course, we stopped the rituximab, and the patient was monitored with infection history, specific antibodies, and it was deemed that the patient did not need immunoglobulin replacement. But we undertook a gene panel, and genetic testing showed a variant in TNF-SF12. This gene has been reported to be associated with CVID, but not this particular variant. So at the moment, we're doing functional studies to see if this is actually clinically relevant to this patient. And so that's the basis of this another study that we have funded, which is to look at patients who develop persistent hypogamma after rituximab, particularly pediatric, as to whether they have an underlying inborn error of immunity that's being revealed by the B-cell therapy. So in conclusion, in this monitoring audit, we were very good at baseline measures. So baseline was almost always done in all categories. I said nephrotic syndrome was a little bit lower than the others. And it's really important to measure baseline, because baseline IgG was abnormal in 25% of patients. If you don't have the baseline, you don't know whether baseline levels were low because of immunosuppression or because of, for example, nephrotic syndrome, where other patients had low levels because they were losing immunoglobulin in the urine. So the baseline measurement is very important. Otherwise, you'd blame it on the rituximab, whereas they already had low levels. Monitoring was not so good, and again, there is a difference you can see between the specialties. There seems to be a different awareness of the importance of monitoring between the specialties. And so this is an area that we really should improve on. And again, it's also important because, for example, this patient with SLE, if we didn't monitor, we wouldn't have picked up that she dropped her immunoglobulin so acutely and then went on to stop the rituximab to prevent her from having permanent hypogam, and also would not have realized that we needed to investigate further. So our recommendations are as follows. We really should try to implement a protocol-driven approach so it standardizes collection time points, both baseline and during follow-up, according to the guidance. We've automated this now, so we have a immunoglobulin order as part of a combined electronic order, which includes pharmacy and pathology, as well as radiology, in fact. If patients do become hypogamma persistently, rather than someone who's transiently, it's important to refer for clinical immunology review. And if they have recurrent or severe infections, that particularly highlights the issue. But we found that many patients carry on having these infections and never referred for review. And lastly, again, it's not just the number. It's not that they're low. It's are they low and are they symptomatic? So it's the combination. The patient I showed you, we never started immunoglobulin replacement, although her IgG was persistently low at 3 grams per liter. The clinical features are more important. So thank you very much for your